So just to provide some quick context for the presentation this morning, we talked about it the last meeting a little bit, but when the downtown district started in 2012, it looked very different than it does today. And there were a lot of partners and pieces put in motion at that time that this organization has been a part of. And we often talk about the state of downtown and the health of the community and the health of downtown and where are we at today. This morning we're going to, basically these presentations will be to really indicate like what's happening out there and what can happen in the future from something that we start every day. So thank you, Katie, for lining this all up. Matt Miller will be the first to give the presentation, and I'm just meeting Matt today, so I'm really glad about that because we've heard a lot about the Access Center. So he's going to speak to that, and I think it has a new name. So Matt, you'll have to share some of that. But I think many of us have heard about the Access Center. And then we're also going to hear next from Officer Dave Schwint, and as you all know, he was our initial downtown Iowa City Police Department liaison who did incredible work, and so we'll hear from him. Chrissy Kinganelli, of course, the Executive Director of Shelter House, and where we're sitting at today with Crosspark Place is a big piece of her work, and she's going to share the progress there. And then last, Officer Colin Fowler, who is our currently time Iowa City Police Department liaison, who's can also speak to what's happening downtown today. So thank you for your attention, and then I'll pass it over to Matt. Thank you very much.
Thank you. All right, I appreciate you guys having me today. As mentioned, the Access Center actually has a new name. I've got the logo and name up there for you right there. So that's kind of hot off the press. It's going to be called the GuideLink Center, just to kind of differentiate ourselves from other access centers that may be popping up around the state. So no further ado, next. So I'll kind of try to buzz through this relatively quickly. I'm sure you guys will have a lot of questions, so I'll try to leave plenty of time for that. If you want to go to the next. The history of the Access Center, there's been discussions to get this off the ground for quite some time. From what I understand, groups of folks have been meeting since 2010 roughly to discuss ways that we could better coordinate services in the area. In January of 2016, a large group from the area went down to San Antonio to see what they've done down there with their restoration center. That's kind of been the model for us. The restoration center in San Antonio was put together essentially to help them increase tourism in the Riverwalk area and have a safe place to go for people, diverting them from emergency rooms and diverting them from jails. In January of 2018, Governor Reynolds mentioned access centers in her State of the State address, and shortly thereafter, Chapter 24 rules were updated to kind of mandate that there be at least 6 access centers throughout the state. And then in May 2018, I think people in the area got pretty serious about getting this off the ground, so they hired me to help do that. So it's been about 1.5 years, almost 2 years, that we've been actually making progress on getting a building built and everything. Lots of community people have been involved in this process. This set of logos actually probably doesn't even encapsulate everyone, but those are like some core members that have been on our steering committees, that had gone to San Antonio, that have been providing input and really helping us get this off the ground. So it's really been great to see what a community effort this is. So you're probably actually wondering, what is an access center? Like, what's the point of it? I know when I took over the project, I had no clue what access center was. That name didn't make any sense to me. I think a better way to think of it is a behavioral health and substance abuse urgent care clinic. Like, we have quick care places you go if you have strep throat or pink eye or something like that, but there's really no places to go if you're experiencing a mental health crisis or if you're dealing with substance abuse crisis other than the emergency room. So this is sort of like an in-between place people can go. A quick way to get folks stabilized and get them connected with ongoing resources. On this slide, you can't see the colors very well, but the state rules on what an access center has are not as robust as the services we're actually going to have at our center. We're definitely tailoring ours to meet the needs of the community. As I mentioned, this has kind of been being talked about for several years before access centers were even a thing statewide. So we really want to make sure this is tailored to meet our community needs. Essentially, on the mental health side of things, as I mentioned, it's a quick way to get someone stabilized and connected with ongoing resources. I have a few different things listed there: crisis observation, crisis stabilization, and subacute care. Really, the easiest way to think of those is just the amount of time that you're there. Crisis observation is like basically a billing code if you're there for less than 23 hours and comes with a certain level of services. If you need to be there anything over 23 hours up to 5 days, that would be considered crisis stabilization. And then we'll also have an affiliation with an off-site place where folks can go for subacute care, which is anything over 5 days, up to 10 days, and you can actually re-up for, I think, several 10-day periods. That'll be located off-site from us, though. So essentially on-site, we'll be doing crisis obs, crisis stabilization. We're also going to have, as I mentioned, substance abuse care there, detox. That's a little bit longer term stay as well for folks who are trying to get over something before entering a treatment program. And then a sobering unit, which is literally just a place to sober up, just as it sounds. A safe environment. It's going to be monitored by paramedics, basically to divert folks who would normally be getting public intoxes or those sorts of things. Also have some medical first aid on site too, because once again, the goal here is to keep people out of emergency rooms, out of jails. Additional services on site. So the community mobile crisis outreach team is going to be located there permanently, kind of their new permanent location. They're actually going to help out with evaluations and triages, so it's great to have them there. If you're not familiar with their program, they've been in existence for quite some time. They're dispatched out to go where folks are experiencing those crises. Could be their home, could be a school, wherever. They're actually going to be helping out on site, and it's going to be a great partnership. They can go out, and if they're meeting with people in the community that would be a great candidate to come back to the Access Center, they can help get them there as well. Also, right next door to us, connected with a Sally Port, is going to be the new permanent location of the Low Barrier Winter Shelter, which is an operation pretty much December through March every year. For those months when it's not in use, it's going to be a great multi-use building where there can be community events, trainings, things of that nature. So we've designed that building to be very flexible. Once again, it's a separate program. It's going to be run by Shelter House as it always has been, but the building's going to be right there connected with ours. We've talked about phase 2 initiatives too, things that we want to expand to once this gets off the ground. That would be including like a MAT clinic for opioid to help with getting folks off the opioids. Also primary care and dental care as well. Staff is going to be provided by a lot of different folks. I'll let you go to the next slide to kind of show the structure of this. So it is going to be like a Johnson County backed entity. And really when we talk about GuideLink Center, Access Center, it's actually going to be made up of various service providers that are all operating under their current licensure and their current tax IDs and doing their own billing as well. It's not necessarily the most ideal model for long term, but definitely for the short term, it's the quickest way to get things set up and get this off the ground. We're hiring Abbey Health to be the managing entity of this. They're headquartered, I think, in Hiawatha. They have a lot of operations in Cedar Rapids. Also, the Abbey Mental Health Clinic, which is here in Iowa City, kind of falls under that umbrella as well. So they have a lot of expertise in this field. So they'll be managing the day-to-day, making sure bills are paid, making sure staffing is done, making sure we're reporting as necessary. From there, then we have 4 essential providers of this. So Abbey Community Mental Health Clinic is going to be providing the actual professional services. So any licensed independent social workers, any prescribers that come on site, they'll be hired by them. Penn Center will be running the crisis observation and crisis stabilization units with RNs and things, different positions like that. As I mentioned, Community Mobile Crisis Team will be there to do the initial evaluations. And then we've got Prelude, who's the existing folks here in town that do a lot of the substance abuse. So they'll be monitoring the sobering unit and also providing those detox services. Now, staffing in Johnson County, as you guys I'm sure know, is very competitive. That's always something that's tough to do. So we're actually going to rely on a few other folks to hopefully help us staff this. So if we need to lean on like the College of Nursing, for example, we're actually having discussions with them about what services they can help provide. So we'll just have some agreements with them if they can provide an RN or an ARMP, whatever positions we can help fill in the gaps. So we're really trying to make this a community effort where we're kind of, I want to say cobbling it together, I guess, from a lot of different entities here. If you want to go to the next one. So the benefits hopefully are pretty straightforward. Basically, we're trying to avoid overly medicalizing or criminalizing folks undergoing a mental health crisis and or substance abuse. A lot of the time they're one and the same. I think a lot of times folks are abusing drugs to get over mental health or vice versa. So historically those have been separated, but I think we all know that oftentimes those are co-occurring. It's going to hopefully make things more efficient with the emergency rooms and with our law enforcement agencies. There are times when people should definitely still go to the emergency room. But if you look at national statistics and places where access centers have already opened up, roughly 70 to 75% of folks who present to emergency rooms could be dealt with at access centers. And so that is going to free up, for the sick to actually be in your emergency rooms. Let us deal with those other folks that just need that short-term stabilization, not quite as acute care. Same thing with jails as well. We all know those are probably the biggest houser of folks experiencing mental health crises right now. So it's keeping them out of jail, keeping them to where they're actually getting treatment, and hopefully breaking that cycle where they're just going between the ER and jails. There's some recognized cost efficiencies here as well. I just threw a couple statistics up there for you. One of these opened in Kansas City relatively recently, and they've shown a lot of great savings to taxpayers via those diversions. Same way with that San Antonio program I mentioned earlier. They showed over a 5-year period saving $50 million in just diversions from ERs and from jails. So major helps to the taxpayers, major helps to your healthcare institutions, to insurers, all that. So our capital funding for this project, so all in to get this up and running, about $10.1 million. And you can see we're actually really close to having full funding for this. So it's really been great. I also like to point out just how many different entities are involved with this. I mean, Iowa County donated $100,000 to this. Obviously Johnson County is a big backer, but Iowa City, Coralville, all of those, you can just see the list goes on and on. So it's really great to see all the different municipalities and entities within Johnson County and outside counties really pitching in to help get this off the ground. So the location of this, we're actually really close to it now. That would be the waterfront Hy-Vee. So you can drive by, we've actually got construction going right here. And if you want to go to the next slide, that's sort of what the building's going to look like. It's roughly the size of a football field. It's 23,000 square feet. Literally, it's the dimensions of a football field. If you want to go to the next one, this is our floor plan. The low barrier winter shelter is on this side. We've got that connecting sally port there where like law enforcement and ambulances can do drop-offs. And then this side is our access center. This is basically the clinical area where you've got folks who are actually like where the patient areas are. There's going to be an exterior courtyard here on the north side. And then this side is essentially administration and office areas. We've also got shelf space here to where we can expand, either expansion of our current services or adding those new services I mentioned, like a MAT clinic or offer primary care, something like that. That's kind of an artist rendering of what it's going to look like. We've got solar panels on the roof. We really designed this building to be super efficient and made for long-term cost savings. It's sometimes easier to get capital things covered than it is ongoing operational. So we really wanted to make this as efficient as possible. If you want to go to the next, that's another rendering. If you're looking at it going down the long way, you see the bump outs. If you want to go to the next one, that's a view from the back. You can see like that law enforcement vehicle pulling through that Sally Port area. So the winter shelter would be closest to us, and then the access center going across there. We've got individual rooms around the outside. So that's these lower ceiling areas. Then in the middle, it's going to be a big open area with windows that get light there into the area. The goal of this is to make it not seem like an institution. We don't want it to feel like a hospital or any medical clinic. We're trying to get a welcoming, warm environment. So really that's the aesthetic we're going for. As far as the timeline goes, as I mentioned, I was hired in May of 2018. A lot of project planning went into this, rezoning, meeting with architects, meeting with service providers. I'm sure you can imagine all that goes into that. We did have land purchase in 2018. Construction is underway right now. As far as upcoming things, we really hope that building's going to be done in November. We'll have about a month or so of training with the staff, and then we'll open our doors this December. So that's really our goal.
Good morning. My name is Dave Schwint. For those of you who don't know me, I work at the Iowa City Police Department, and I was the first downtown liaison officer. So that position kind of the idea started back in 2012 when the downtown was seeing some really increasing problems, behavior issues, safety problems, and we were getting a lot of feedback that people just didn't feel safe or comfortable going downtown with all the things going on. And there were a number of things contributing to that. I'll let Nancy jump in if I get anything wrong here, but it sounds like as I understand it, the downtown district talked to the city about creating a position specific for that area. The district even offered to put in some funding to help offset the costs, and the city decided to establish this downtown liaison officer. So if you click to the next. So that started in 2012, and that sounded like that kind of got established. So in January of 2013, I was selected to get this position. There were a few of us at the police department that kind of interviewed for it. It was interesting. We didn't really know what we were interviewing for. Nobody had done it. We just kind of knew we need you to go downtown and spend some time, solve some problems, but we're not really sure what it's going to look like. And okay, interesting problem. I'll go ahead and shoot for that. And so I started in January of 2013. One of the things I learned pretty quickly down there, we already knew, but we didn't have the staffing and time to really follow up on it, was we were seeing a lot of problems. We were starting to see some bath salts being sold from a retail establishment, and kind of the first signs of the synthetic marijuana type products being sold off the shelf as incense. And we were seeing a lot of behavior problems, health problems, fights, and things going on with that. So that was one of the things I started working with on our, when I was down there with our drug task force member. And so we did a couple of federal search warrants at a couple of establishments downtown in 2013 to try and really put a stop to that, but that was more focused on the bath salts because that was more established at the time. This whole synthetic marijuana was just starting to become a thing, so we didn't really have enough to follow up on that at the time. Also, through my work downtown, I kind of learned that it was important to get to know the people who were on the street, not just kind of arrest them and take them to jail, because then they just get out the next day and they're mad at me and won't talk to me anymore. So I used to just kind of laugh inside that I would come downtown in the morning, get a coffee, and I'd go sit on the bench with somebody who was living on the street and just talk to them. And people would walk by and say, "Hey, thanks for being down here. Great to see you." And I'm like, I'm just sitting on a bench having coffee. This job is perfect. Like, how does it get any better? And this is a government job right here, you know? So through my work that way, I got invited to come sit in on this local homeless coordinating board. Had never heard of it, didn't know what it was. I understood it was a bunch of service providers, and in the line of work I was in, it kind of sounded touchy-feely, and like, I don't know what I can provide, but I'll go sit in. And I was kind of amazed with my first visit there. So early on, there was this discussion of establishing a housing first project. What can we do to get a housing first project in Iowa City? I didn't know what it was, so they explained it to me, and they were trying to determine, like, how can we study the individuals who are living on our street to find out what they're really costing us now, just being on the street, going in and out of jail and in and out of the hospitals, and does anybody want to work on a subcommittee for this? I was new, and I want to impress people, so I'm like, hey, I'll help. I've got data, I can look stuff up. And so I kind of volunteered to be part of that initial study, and really glad I did. It's going backwards, yeah. So along the same time as we're working on kind of starting this study, this synthetic marijuana thing continues to grow. And so we started following up on that, investigating that, doing some controlled purchases and sending stuff to labs and working with the U.S. Attorney's Office. And I mean, there was really a lot of days I worked with the task force officer, 16-hour days, 7 days a week, as we were trying to work through these things and get them handled. And then in during 2014, we did that second round, and we actually did 4 simultaneous federal search warrants at 4 different businesses to try and shut that down, and really did an effective job of shutting those retail sales down, which was key to us because we were seeing people smoking this and literally on their hands and knees crawling down the double yellow lines of Burlington Street because they didn't know where they were and they were just trying to find something. Had a couple of people pass away on the street from smoking the stuff because as these products were being developed and sold, the DEA would do emergency scheduling and make these substances illegal. And so the chemists would tweak one electron, it's now a different chemical substance, and we'll resell more. And they tweaked it so many times, there was no human trials or anything, and there was just a lot of health problems. And so that was kind of one of the big key works we did down there. In 2015, worked with Shelter House, and they established the winter shelter, which was a big one for us because a lot of the problems we had during the wintertime was just people trying to not freeze to death. They were going into apartment buildings, they were sleeping in laundry rooms, coming into businesses and falling asleep, et cetera, and just creating a lot of unintended issues. And so the winter shelter was established to do that, run by Shelter House. I think the first time was at the Aldi's building. It was kind of at the time wherever we could get space to put it. And through this time, we're continuing to work on that Housing First study. And as we pulled that data together in a very manual way, we built out these profiles of 4 individuals and found that of these 4 individuals, they were using about $140,000 per person per year of services in our area, but they were all still on the streets. And Chrissy and her staff worked, and they were kind of putting that information out there, and I think applying for grants and such. And Chrissy got an invitation to go to the Obama White House for this new thing called data-driven justice. And she let me tag along with that. And so we got to go out there and learn about how this work was being done in other areas, what people were doing, what didn't work and stuff, and got into that from there. As we worked through that organization, kind of continued to build our data work here, in 2017, we got chosen as one of 3 pilot sites nationwide for this data-driven justice. And it all goes back to that original work we did in that subcommittee in order to establish, the building you're sitting in here. 2017, as Chrissy and her staff did their work, we got $3.1 million-ish of funds to establish this project here. And as we continued working on the data-driven justice part and bringing the data together, we were awarded an Amazon Web Services City on a Cloud Award. So one of 3 in the nation that got that award too for the work we were doing on the housing data. And then, we come into 2018 where they started construction of this building, and which opened just over a year ago last month. And so January 19 was the launch. And, I think when I was in the downtown position, I spent a lot of time, and a lot of you saw me downtown talking to people and just being present. But there were also a lot of times I wasn't present. And, I would have the questions, hey, I haven't seen you in a while. And at the time, some of those I was working long days and hours and nights on those warrants, and we couldn't go out and say that. We couldn't do press releases. Or I was out trying to work on data and pull stuff together to try and help with this study. And so one thing I'd like to say, both to Nancy and everybody in the downtown, is that I'm very appreciative that you gave me the time to kind of look at long-term solutions and work on long-term solutions, because I think we were able to kind of bringing everybody together make some real differences downtown for both the safety of the area and then better outcomes for the individuals that were living on the streets down there. So I'll let Chrissy take it over on how this project's working out.
So I'm a little shorter. Is this okay? Okay. My name's Chrissy Canganelli. I'm Executive Director of Shelter House, and welcome to Crosspark Place. I want to start my portion of today's conversation with just some terminology that we consistently use. This is pretty thick with terminology. And talk about, first of all, permanent supportive housing and what it is. Permanent supportive housing is combining affordable housing with supports necessary to help people maintain that housing. I mean, that's the crux of it. The full definition is up here. So voluntary support services designed to help tenants stay housed and address their health issues, and building on the necessary skills to live as independently as possible. Permanent supportive housing is evidence-based, and it's prioritized for individuals that have complex health and behavioral health issues. This terminology is something we stick very closely to. It's HUD-driven. It gets watered down sometimes in our communities throughout the country as different entities start using the language, but we're pretty conservative and strict here in how we understand how this language should be used. Does that make sense? It's important to us. We also, as we're moving forward with permanent supportive housing and consistent with HUD's guidelines, we're targeting this intervention, if you will, for individuals for whom homelessness has become a chronic condition. Through the evidence, we're able to show that permanent supportive housing reduces returns to jail, reduces utilization in medical systems, reliance on emergency health services, and overall improves the quality of life. Next slide, please. The other really significant concept here is housing first. And Dave mentioned housing first. I want to talk about this because it's really a game changer and a paradigm shift for us. We have, throughout the years, followed a method that has been consistent across the country in how we've delivered our services in Johnson County, and it's been using a housing-ready approach, which has meant that through Shelter House, we've worked with individuals to help them in the past kind of work their way back into housing, from emergency shelter through case management, helping them find a job, save money, heavy emphasis in the past on demonstrating med compliance, sobriety, all these different things. Well, our learned experience and that of providers across this nation has been that Housing Ready imposes just incredible barriers for people to actually being able to get into housing and to move on with their life. This has taken us years to do this paradigm shift internally within our organization, but we've fully completed that and now really are consistent with this housing first approach throughout all services at Shelter House. For the housing part of it, what this means is that people's access to housing should not be predicated on their ability to demonstrate sobriety, med compliance, or an ability and desire to work. Housing is essential. Housing is a human right. And that, in fact, by providing housing as that first step, getting people into housing, they're able to actually address their health issues, their self-care, but allowing those things to be done voluntarily by the individual increases engagement, increases the efficacy of all of our work in just a phenomenally, exponentially different way. It is the understanding that these other issues as far as employment, attending to health issues, connecting with different providers in the community, all of that outreach, it's necessary and incumbent for us as providers to be able to provide those access points for individuals that we're housing. But again, it's voluntary on the part of the individual to engage in those services. So it's very different from how we've been for like the first 20 years. Crosspark Place, Dave showed the timeline overall as to how this work has moved forward over the last 5-6 years. But specific, there's kind of a tangential or what is the word? I'll say tangential timeline that runs along his timeline as well. So I'm going to go back and forth into his information a little bit from a different lens slightly. Back in 2014-15 is when we started that work group that Dave mentioned and he served on. In fact, he was one of the primary workhorses of that group. Pulled together this cross-system work group that had everyone from our Housing Authority, Iowa City Police Department, Housing Trust Fund of Johnson County, Shelter House, Abbey Health, Prelude Behavioral Services. It really was cross-system. University of Iowa Hospitals and Clinics was another important partner in that work. And developed those case studies. We've shared some of that information with this group before. Dave mentioned that the case studies for individuals who are known to be chronically homeless and living on our streets and understood to be frequently cycling through these different systems, criminal justice, health, human services. And each time cycling back to the street in worse condition than the time before. Through our analysis of their experiences, we found that those individuals were costing our community about an average of $140,000 per person per year, all to end up recidivating back to our streets. The total cost over that period, that study period, was $2.16 million. The vast majority of the expenditures being health-related expenditures, about 80%. And our findings actually were very consistent with the findings of communities across this country that had undertaken that same kind of analysis, known today as frequent user system engagement. Not very sexy terminology, but that's what it is in our world. The winter shelter began in January of 2015, and it's consistently occurred each winter, early December through mid-March each year since. We're looking forward to wrapping that up this year. Spring seems to be around the corner. The impact of the providing that winter shelter intervention, which I'll say is in addition to our existing shelter at Southgate Avenue. The expansion of that shelter service, which is really focused to that typically unsheltered, chronically homeless population that are not coming into our other existing shelter services. The police department specifically was able to see a change of between anywhere from 67 to 74% decreases in calls for service related to vagrancy during the times of service that the shelter was available. Anecdotally, we know that emergency room utilization dropped precipitously, ambulance services dropped precipitously. We hope to be able to have the hard data of that moving forward, but we don't. The only real data point that we have is from the police department, but that's a significant indicator. The City of Iowa City, as they became more informed about our opportunity to do something different to address the needs of people who are unsheltered and our desire to provide permanent supportive housing for individuals that were currently living on our streets, they worked with us to amend the zoning code. I'd say along the way, this project has been incredibly inspiring. It's been cathartic for me personally because of the desire of the different sectors of our community to become involved in being a part of a long-term solution. This entity here today, your board, very informed and actively involved in the beginning in helping us to educate the community early on. City of Iowa City, incredible support from them in actually amending the housing code and creating a new housing type, long-term community housing, which allowed us to be able to actually move forward with the development of this project without facing years of legal opposition and litigation. We were able to use this land outright. We purchased this land in October of 2016. We had the groundbreaking in 2018. So it's moved forward in a way that my past experience really, I was not able to wrap my head around. I've had a different experience in trying to develop the emergency shelter years ago. So project funds were fully committed by July of 2018. We did have $3.1 million in grants, $425,000 in loans in combination from National Housing Trust Fund dollars and our own local housing trust fund of Johnson County. Johnson County, the county itself, and other private donors actually funded all of the furnishings within the building and equipment. So the only debt that we have is a $425,000 loan, which is really significant for us to be able to minimize the debt on the project. The Iowa City Housing Authority, which was a partner from the very beginning, through their leadership, they amended their administrative plan and project-based vouchers for Crosspark Place tenant for this building and for the tenants here, which means that we're guaranteed rent revenue. That was no easy task, and it's been years in the making in developing the relationship and the understanding with leadership at the Iowa City Housing Authority. So I applaud and highly regard Steve Rackus there for the work and the leadership that he's demonstrated. This is not something that is consistently happening across our state, these partnerships with housing authorities, so it's really quite extraordinary. Some rules needed, local restrictions needed to be relaxed to be able to make those vouchers available in a real way for the prospective tenants here. The federal guidelines were not changed, meaning that the restrictions on those vouchers are that you cannot have manufactured meth in a publicly assisted housing unit and you cannot be a registered sex offender. So those are the only two exclusions. Yeah, I'll have cognitive dissonance if we don't. The construction was completed in January of 2019, and we were at full occupancy by June of 2019. That sounds like a little bit of a stretch of time there, but I want to talk about why that is. So now, okay, in the next one. Yep. Oh, that one's out of order. Before I talk about that, I guess one of the other things, we've talked about the use of the case studies in informing and educating the community the change in the vagrancy calls. So data has informed this work and the development of Crosspark Place all along the way. The thing that doesn't quite fit in here, but it is just kind of jumping around in the background all the time, is that as we were moving forward with the stakeholder group and kind of those outward-facing relationships, we did our own internal analysis on impact that we were seeing through a permanent supportive housing program that we had offered through since 2011 called the Fairweather Lodge. It's a scattered site model. Individuals live in community, 5 to 6 adults in each house. And these are individuals that have experienced homelessness and have a serious persistent mental illness, so diagnoses of schizophrenia, bipolar disorder, serious depression. Not necessarily chronically homeless though, so a slightly different population than who we were really targeting for here. And this was the kind of information, the findings, the analysis that we took away from looking at individuals' experience pre-housing versus post-housing. So the experience that they had in the years leading up to actually being placed in permanent supportive housing, we saw a change. Psychiatric stays decreased by 90%, hospital stays by 79%, ER visits decreased by 90%, inpatient treatment 90%, and jail stays just under 100% change in that utilization. Prison at 100%. So overall, the cost and the change of service utilized by these individuals that were in our Fairweather Lodge program, a decrease in the cost for their care, and this includes the cost of the housing, decrease of 82%. Typically across the country, providers are seeing a cost change about 60%. I add this in here because this was kind of the other dimension that was informing our desire to expand permanent supportive housing and make it available to a broader net of individuals. Does that make sense? Okay, thank you. So going back to Crosspark Place, why did it take us 6 months to get people housed in the building once we were finally, and it wasn't 6 months, it was about 5.5 months to get them moved in once we were finally ready for occupancy. The outreach for identifying individuals began in June of 2018, and over time we identified about 90 individuals who were on our referral list. Every person that was identified came through what's called our coordinated entry process. We have a weekly meeting where providers from across the community are sitting down and identifying people based on need and kind of targeting the different housing solutions that we have available in our community for folks. So again, data is informing our decision making from the beginning on throughout today. For the individuals that we were prioritizing here, we had kind of some local criteria that through that stakeholder group we had defined over time. We were looking for folks that had a minimum of 2 interactions with local law enforcement over a 3-year period of time, minimum of 3 interactions with local service providers. They could not be a registered sex offender. They could not have manufactured meth, as I mentioned before. And then the use of what's known as the VI-SPDAD, and that's an acronym. I cannot remember what it all stands for, but it's a vulnerability index that is used across the country to assess the acuity of need for individuals that are experiencing homelessness. And from individual scores on this vulnerability index, targeting different housing interventions. So folks with the highest acuity of need, we were prioritizing for Crosspark Place in combination with these other criteria. 15 out of the 24 met the local cost threshold, and it was about $45,000 per year that we were looking at as that minimum threshold of locally incurred costs. Dave, do you want to talk about, where'd Dave go?
All right.
Talk about, this is what individuals looked like from a data perspective that were identified and became Crosspark tenants.
So as the staff was looking at the eligibility for different individuals, they were collecting information from hospital, ambulance, law enforcement, a number of different service providers, and putting that together to see what their service utilization looked like. So this graph just shows each of the original individuals' initials along the bottom, and then their medical costs for the 4 years prior to moving into here. And you can see there's quite a range. But the average, and I wish I should have added it on the graph here, the average is about $360,000 per person, I think is what it was, just from ER visits and other things. So this is just the medical costs. If you go to the next slide, here we just add in other costs, so jail stays, police time, those kinds of things. You can see how little of the percentage that is actually taken up by the legal and corrections type costs. It's mainly all medical. So, one of the big goals is what can we do to put a dent in that usage of emergency departments and hospital admissions and such. But we are talking some pretty significant numbers across the individuals who moved in here.
So we have 24 single one-bedroom apartments. I'll add also that Neumann Munson is a downtown business, donated all the architectural services for this project over the life of the project. HBK donated the engineering. Modus also donated engineering services. So for the 24 tenants, this is what tenant engagement looks like here. We have on-site case management. Again, it's voluntary, but we make those services on-site. The primary focus of the individual case manager's role is to help in any radical way possible to help people sustain their housing and maintain their housing. These are the other things that they're working on as they're doing that, though. Securing income, so applying for Social Security, disability benefits, VA benefits if they've not accessed that. Looking for any type of those income sources that they're going to qualify for. Managing medical needs and appointments, navigating the criminal justice system. Oftentimes people come in, they've got ongoing issues that they've got to attend to, helping to structure what needs to happen next to not have that turn into something worse. Independent living skills, so helping with maintaining the apartment, housekeeping, different things like that is how rapport is initially built. It's really important. People have been living outdoors and are not used to maintaining an internal environment. And then other client-driven goals, really important to understand what people want to do next in their lives as they can start to think about this. What's not really being able to be captured by a slide here is to talk about just the incredible transition that this takes for a person to move from having lived outdoors, some folks for over 30 years, they've been homeless, to coming inside and working through and helping people through that process. There's no way to be able to anticipate what that looks like and feels like or how to be prepared to help people really adjust and work through that until you're in the throes of it, frankly. And also want to make sure that we mention here that what we're practicing here as part of the Housing First approach is a harm reduction method, which is, like I said, we're not asking people to be sober, become med compliant to come into or to stay and continue to live here. Harm reduction has everything to do with building rapport and relationship and trust with our tenants, and harm reduction it's very creative in understanding how we can help to work to, through a motivational way, help people consider the different options that they have in front of them and possibilities of making more healthy choices. So this is just it looks like a very random list, starting off with Mountain Dew. I'm sure you're like, what the heck is Mountain Dew doing up there? Well, we've got somebody who requires a shot on a regular basis to maintain their mental health, and that individual was not remembering to take that shot. The case manager found out that they love Mountain Dew. If we keep the refrigerator stocked with Mountain Dew, we know that the individual will come down, they'll have a Mountain Dew, and they're also going to take their shot. Vaping instead of smoking cigarettes, decreased liquor utilization. So we have an individual tenant that wanted a game system. I don't know which one it is. Xbox, that's important, and had always wanted one for a really long time, but living outdoors did not have the ability to do that, didn't have income at the time either. Now has their own home, has Social Security benefits. One of the first things that individual wanted to do was save towards getting a game system. That individual has been sober since they've had the game system. That may sound trite, and I don't mean it to, but you just don't know when something that is really simple can be literally a game changer, and I did not mean that as a pun, a life changer for someone. And it's just a step. That doesn't mean that, you know, other things aren't going to happen, but it is a significant step. And it changes the person's ability to understand who they are and what they're capable of in relationship to the world around them and the rest of their lives. They start thinking about the rest of their lives. The other thing too, we have on-site medical and behavioral health clinical services. So along the way, I've highlighted some of the partnerships that were necessary to make this a reality. We have on-site psychiatric care through University of Iowa Psychiatry, UIHC Psychiatry, and College of Nursing is providing medical services on site. Next slide, please. So this is just some of the information. We don't have access to all of before and after, and it's very early for kind of after housing kind of impact information. But we did pull out a couple of different individuals and look at what has been the impact since they have been housed. So for one tenant, we have UIHC billed costs between April of 2018 and April of 2019. You'll see it just over $585,000 for that individual. They moved into Crosspark Place in April of 2019. And at the time this analysis was done, we looked at the impact from that move-in date through mid-November, which was what we had data for. And their cost utilization was down to just over $150,000 for that person for their medical costs. Another tenant, UIHC billed costs between the 2018 and 2019 year of just over $211,000. They moved in February of 2019, and so their after care $957. So we're seeing some initial really substantial changes on the medical, which is very encouraging. It's what we expected, it's what we hoped, and it's what we want to see continuing forward. And I'll also say this is, they're sustaining their housing, but they have quality of care. So these changes in costs are not indicative of some kind of change in substantive care. It's better care, because it's meeting them where they are. I'll let Dave speak to the change in the jail utilization.
Another one of the outcomes we were interested in looking at beyond the medical was the jail stays. So what's their involvement like, or how has it changed with the criminal justice system? And so if you see the vertical dashed line there, that's the housing line. So a number of the individuals here moved in at different times, but if we put them kind of line up the date they moved in here all at the same time, that's the introduction to housing. So I went back 3 years and totaled up the number of jail stays for every quarter. So there's 12 quarters prior to housing there. And on average, those residents spent 107 days in jail every quarter before housing. The first quarter after housing, that average dropped down, so now it's just 73 in that first quarter. The second quarter was only 5 days in jail for all of the tenants here combined, and the third quarter was 8. So that second quarter, that 5 days is made up of 2 people, and the 8 is made up of 2 people, but neither of them are duplicated. So it's not even like it's 2 people taking up those 5 and the 8. It's just people who had a bump in the road and found themselves in jail for a couple of days. But you know, we're seeing an over 90% decrease in jail stays there, which is just, it's far beyond what I expected it to be. So we're getting to the point, as they've mentioned, about dates moving in. We haven't been able to compile the fourth quarter for everybody yet. So we look forward to kind of continuing to update this as we can as those anniversaries come around.
So something I did not mention about the 24 tenants here, that part of that definition of chronically homeless, it's not just having to do with the length of or the number of episodes that somebody has experienced homelessness. The other part of that definition is that people demonstrate, and we have to prove that they have a disabling condition. So everyone here has at least one, if not multiple, disabling conditions. And I think that that's an important contextual element of the story here. What does moving on look like? We have 24 units. this can be people's permanent home. We encourage people to live here permanently. They have a lease. It's renewable after a year on an annual basis. It looks like the lease that anyone else who is renting in our community would have. But for some people, this coming in, moving in here is a door to another and better intervention, if you will. This is what moving on looked like for one of the tenants recently who had been homeless for decades. He moved into Crosspark Place, lived here for only 7 months. He required a higher level of care than we were able to provide here, and we knew that as we were bringing him in here. Frankly, he was moved to an assisted living facility after here. He could not go from a homeless situation to an assisted living situation. That's just not an allowed and permitted thing within the system that we have in the state of Iowa. So it's a barrier, and it may not make logical sense that this is what we have, but it is. We were able to establish the record. He had an address, and we got him to the level of care that he needed to get to. Moving on can also look like moving into the local market, into regular any other unassisted housing unit in the community. People, if they want to and are ready to do that, we're happy to help them move into a location in the community and make sure that they're connected with the resources that they need. We can continue to help them with those services if they need. We don't have to. We want to encourage people to move on in their lives as makes sense for them. As I mentioned, we had a waiting list or referral list originally of 90 names. So we want to be able to expand this service and resource in as best a way and most efficiently as we can. But there is going to naturally over time be some moving on from here. And with that, we've got a postscript Colin, Officer Fowler, is going to be able to provide about the immediate impact that all of you are seeing in the downtown area.
I'm as tall as you. What to do? Not to change it at all. I'm Colin Fowler. I'm the current downtown daytime liaison officer. I took over in 2017 after Dave did it for 5 years, and as you can tell by the numbers, he did a great job. Word to the wise, never take over a job after Dave's done it for 5 years. just not a great idea, but here I am. So for all the years he did it, I was assigned to downtown as a regular beat officer. So we would work very frequently with the same populations. So we knew everybody by first name, who they were dating, where they were from, what their triggers were. I would sit down and have coffee, just like he would. So it was pretty natural for me to take over after he moved on. It was not uncommon for us to deal with the same people several times a shift, which got frustrating. So we would come in and make, the first time we'd be called, we would fix that, and 2 hours later, someone else was calling. So that would happen over and over for years. And the winter shelter would help, but let me tell you that when this opened, when Crosspark Place opened, the type of decrease, I think she said 67%, that's permanent now for the downtown. Like, it's just so much different landscape. And when they were talking about opening it, I had a healthy dose of skepticism that it would make a huge change. The change it has made in my job and the downtown landscape is far surpasses what I ever would have expected. It's been completely different. You mentioned the Xbox. I know who that is. I was just talking about him last night. I have not seen him since he moved in here, and I would deal with him 3 times a day sometimes. So, and he was just, I'm not sure I'd recognize him if I saw him. I just have not seen him. And that has happened with probably a dozen people I used to deal with every day. That the problem's just fixed, from my point of view. And I've had business owners say the same too. So I kept that brief because I know we're getting a little on time.